Good evening, everyone. So welcome you all in this module 4 of short certificate course on allergen immunotherapy organized by Indian College of Physicians under the guidance of Professor Jyotirmoy Pal, Dean, Indian College of Physicians. We are conducting this course on basics of allergen immunotherapy. Today, the module 4 will be on allergen immunotherapy, what, how, and when. So already we had covered 3 important aspects. In module 1, we learned about the basics of allergy and immunology. Then module 2, we also learned about clinical methods and history taking before prescribing allergen immunotherapy, overall allergy practice, the importance of history taking and clinical methods. The last module, third module, was on skin prick test and its application on allergen immunotherapy and allergy practice we learned. Now today, the module 4 will be on the basics of allergen immunotherapy. The 3 important questions we will discuss today, that is allergen immunotherapy, what is that, how it acts, and when to be used. But more detailed discussion will be on the next module, that is module 5, where we will learn about allergen immunotherapy prescription, how to prescribe allergen immunotherapy. So today we will have first of all one lecture by myself, and followed by, we are really privileged to have with us distinguished allergist in this country. So we will have a panel discussion, and I request you all who are there, if you have any doubt, any question, you can ask our distinguished panelist who will be present with us. So we will have Professor P.A. Mahesh. Mahesh sir is currently professor at the Department of Pulmonary Medicine at JSMC Medical College, Mysore. We also have with us Professor Neeraj Gupta, who is also a renowned allergist in this country. Currently, he is attached with Gangaram Hospital, New Delhi. So, sir will be there in the panel discussion. Also, we are expecting Dr. P.C. Kathuria, sir, who is also a renowned chest physician and allergen immunotherapy specialist from New Delhi. We'll also have with us Dr. Danish Jamal from New Delhi, who is a pulmonologist and allergologist practicing at New Delhi. So with that, we'll start today's session. Just to share my screen first. Can you confirm whether it is visible?
Yes, sir, it's perfectly visible.
Okay, thank you. So let's start today's discussion on allergen immunotherapy. What, when, and how. So what is allergen immunotherapy? We need to understand this definition clearly. This is a process of repeated administration of specific allergens to patients with IgE-mediated condition for the purpose of providing protection against the allergic symptoms and inflammatory reactions associated with natural exposure to those allergens. So this is nothing but a hyposensitization procedure, and we can also call it as allergen specific desensitization. So a few important points here in the definition we need to remember. This is the process of repeated administration of something that is a specific allergens to patients. Which type of patient? That those patients should have some IgE-mediated allergic symptoms. Why we are providing that? The purpose is to produce some level of protection against those allergic symptoms which is associated with natural exposure to those allergens. So when we talk about allergen immunotherapy, it is something which is going to modulate the patient's immune response. So we know we have multiple treatment modalities when we are talking about anti-allergy treatment armamentarium. We have antihistamines, we have inhalational intranasal corticosteroids, we have immunomodulators like cyclosporin in certain conditions. We have leukotriene receptor antagonist. But believe me, this is the only modality which is going to target the T lymphocytes directly. And already we know allergy. In allergy, the basic issue, the master cells is the T cell lymphocytes, which is causing those exaggerated or altered immune response. So if we can target this, that definitely help our patient. So when we talk about allergen immunotherapy, they target T lymphocytes. So Treg cell activity will be more there. That will regulate or suppress the Th2 mediated reactions that already we had discussed in our previous classes. So ultimately, this will attenuate or modify the patient's symptoms upon exposure to that particular antigen. So in nutshell, when we talk about allergen immunotherapy or AIT, this is something which is an immunomodulatory method. Where we use it in treatment of IgE-mediated disease. For an example, the allergic rhinitis, it could be rhinoconjunctivitis, allergic asthma, and also in case of venom hypersensitivity. Why we are using? We are using to control the symptoms of the patient and also to reduce the medication score. How it acts? It decreases the sensitivity of the allergens. So we have to give it in a sequentially increasing dose of antigen. And basic mechanism, by the virtue of this allergen immunotherapy, there will be a shift of the immunological response from Th2 to Th1. So this has a disease modifying effect. There are different routes of introducing allergen immunotherapy. It could be subcutaneous, sublingual, or some other therapies. They are also in the process of investigation how they are actually acting, that had been scrutinized by the scientists, like oral, nasal, bronchial, or even the lymphatic route. So in India, in generally, we are using subcutaneous immunotherapy. Sublingual immunotherapy is not approved at present by our regulators, but hopefully we'll get the approval maybe very soon. But definitely we are using subcutaneous allergen immunotherapy. So this has been taken from our guideline, the paper by Gouresan et al. If you just revisit your first class on basics of allergen immunotherapy, starting from the introduction of the allergen to the system by the defective epithelial barrier, just remember who was there to catch that allergen, the dendritic cell. So even allergen immunotherapy has some role on dendritic cell. After that, you can see all the phases, starting from the T lymphocytes, where the dendritic cell is going to present the antigen, and that T lymphocytes becomes Th2 type, and the lots of cytokines like interleukin 4, interleukin 5, and interleukin 13, that cytokine milieu produce some environment that will actually tell the Th2 cells to contact with B lymphocytes, make them that B lymphocytes, there will be the class switching happen, and ultimately instead of IgG, they will produce IgE. So even allergen immunotherapy will act on those B lymphocytes to prevent those class switching. And we will have the cytokines which are anti-allergic, like interleukin 10. So interleukin 10 is anti to interleukin 4, 5, and interleukin 13. So ultimately, by the virtue of this allergen immunotherapy, in systemic and local, both areas, both zones, there will be less allergen-specific proliferation, less production of Th2 cytokines, that means interleukin 4, 5, and 13, more Th1 cytokines, so more interleukin 10 activity, transforming growth factor beta activity, and also the Treg cells will be activated. So they will tell the B cell not to produce IgE instead of again to produce IgG, especially the IgG1 and IgG4. And there are certain studies which are also suggesting, of course, with sublingual, especially the oral allergen immunotherapy, that it may help to proliferate the mucosal IgA2, which can help in preventing the disintegrity that happen into the mucosa or mucosal epithelium. So that is the beauty of anti-allergen immunotherapy. So when we talk about allergen immunotherapy, many times the patient will ask when this medicine is going to work. Scientifically, it will be effective from day one. From day one, there will be the basophil tolerance that happened and decrease in mast cell basophil activity, which can target the local anaphylaxis. But it is very important to note the clinical effect that will take months to appear, or almost 9 to 12 months that can be taken to have the actual clinical effect. And when we are prescribing allergen immunotherapy, if we not tell this story to the patient, the compliance could be an hindrance then, because the patient will think after 1 month there is no improvement. They will think there is nothing new that had been happened to them. by this allergen immunotherapy. And after 2 months, 3 months, they will stop that allergen immunotherapy with some bad naming of this modality. But from the very first day, if we can tell our patient, this will take some time to have the clinical effect, and in between you also have to continue the medications, whatever we are prescribing. So that can improve the compliance, and that can serve the very purpose of allergen immunotherapy. So they will induce the Treg cell and Breg cell. Therefore, the Treg cells will produce more interleukin-10. Already we know about this, the function of interleukin-10, that decrease the allergen-specific lymphocyte proliferation. So decreased tissue mast cell number also. Eosinophil number will come down, and type 1 hypersensitivity reactions, that means the skin prick test response, that also decreased, but after 6 to 9 months. And there will be some early increase in specific IgE, maybe around 6 months, followed by late decrease in specific IgE. And also around 4 to 6 months, there will be increase in specific IgG4. And some studies also had shown the mucosal IgA and IgG1 also increase. So this is a very important paper by Agdisem et al., where we can see from the very first day, the early basophil tolerance developed and early decrease in mast cell basophil activity for systemic anaphylaxis that happened. Then what happened in the molecular level? There will be inducement of Treg cell and Breg cells. So ultimately, the Th2 suppression will be there. Decreased allergen-specific lymphocyte proliferation will be there in a steady rate. And after some times, maybe around 6 months, there will be decreased number of tissue mast cells and eosinophils and release of the mediator in nasal mucosal biopsies of allergic rhinitis patients. So decreased skin late phase response in parallel to decreased lymphocyte and eosinophil infiltration. That will be some that produce some late effects. So again, the type 1 hypersensitivity, the skin test that will come down after 6 months. There will be some early increase, the green line, we can see here, the green line, there will be an early steep rise in specific IgE. But after 6 months like that, there will be fall. And when we talk about IgG4, maybe after 1 month, there will be a rise in the IgG4 will start rising at around 6 months, and after years, it will attain the peak. But the problem is for human IgG4, how much is the achievable cutoff, that we don't know. So some studies, they had done some ratio between IgG4 and IgE. So gradually, if they see the IgG4 IgE ratio is increasing, so that means the allergen immunotherapy is working in that patient. But at present, for our basic clinical practice, what is important? The clinical symptoms, that is important to monitor, because for seeing the allergen immunotherapy effectiveness, we should not do any this type of costly test in regular settings, like IgG4 IgE testing is not recommended for daily clinical practice. But it is obviously good if we can do some research to see the biomarkers. So again, in this picture, we can see how the Treg activity improved, and if there is increased Treg activity, so Treg cell will be hyperactive, so they will suppress the Th2. They will suppress the endothelial cell mediated secretions, and also the cells like eosinophil, basophil, mast cell, there will be a direct and indirect suppressive effects on those. So the interleukin 10 and TGF beta, they will be more, whereas that Treg cell action on Th2, which ultimately decrease the Th2 cytokines, Th2 mediated cytokines like IL-4, IL-5, and IL-13. And that will help us in the B cell. You can see there will be inducement of IgG4 and again suppression of the IgE. So the class switching that happened from IgG to Ig now reverse by allergen immunotherapy. There will be again production of IgG, especially the IgG4. There are some newer concepts regarding the mechanism of action of allergen immunotherapy. This concept, these studies are suggesting allergen immunotherapy can induce innate lymphoid cells too. I think many of us had gone through a very beautiful slide where we see the different biologics are using in asthma. And the first line, if we just remember, just below the epithelial membrane, the role of innate lymphoid cells had been emphasized. All the reactions start from those ILC, especially the ILC2. And this allergen immunotherapy can induce those ILC2, and that will help in reversing the shift from, they will help to make again Th2 to Th1 back, and suppression of pro-inflammatory allergen specific Th2A cells and follicular helper cells. So T follicular helper cells are also notorious in producing those allergenic cytokines. So they will suppress, the allergen immunotherapy will suppress those. So higher differentiation of secretory and systemic IgA. This is again a newer concept. And the concept of immune tolerance. Just again, this picture, I think many of us had gone through again and again, but this is the basic mechanism of allergy. We all know the allergen, they will be taken by the antigen presenting cell. Of course, here should be that area, the basic defect of allergy, that is the loss of epithelial integrity or defective epithelial integrity. So through that, allergen will enter, and the APC, the antigen presenting cell, will take up those. So allergen immunotherapy, they will act on this antigen presenting cell. Now, when the antigen presenting cell is presenting allergen to the T cell receptor, and they will become from T naive to Th2 type. So that also had been targeted by the allergen immunotherapy. And ultimately, these all will be blocked. So B cell, there will be reclass switching. So where more and more Ig productions are happening here, we know that by the virtue of this all cytokines, the B cell will produce Ig instead of IgG. The class switching happened. But now with allergen immunotherapy, the Treg cell will be activated and they will block this class switching. So ultimately again, we will get IgG. And also the mast cell, the eosinophils, they will be targeted by the allergen immunotherapy. Now, what are the indications for allergen immunotherapy? By definition, we had already know that IgE-mediated disease, more than 5 years. Generally, it is approved in more than 5 years, but I think we will discuss in the panel discussion. This upper limit can be reduced to maybe 3 years also, sometimes 2 years maybe. But of course, that depends on the other clinical situations. We will ask definitely ask Dr. Neeraj Gupta on this perspective, what is his opinion? Because in this area, we will need to have some specific points if we use allergen immunotherapy less than 5 years. Generally, no upper limit, but again, if the age is more, the effectiveness of allergen immunotherapy will be reduced. So the elderly population, it is generally not used. Allergic rhinoconjunctivitis, those who are suffering from moderate to severe intermittent or even mild persistent or moderate to severe persistent variety of allergic rhinoconjunctivitis, there we can use. The controlled cases of allergic asthma, venom allergy, when there is aeroallergen sensitive atopic dermatitis, there also we can use allergen immunotherapy, but the evidence level is low here. So more evidence generation need to be done in this setup of atopic dermatitis. When it will not work? First of all, we need to understand when does it work? 4 important points we need to remember for actually having allergen immunotherapy working. Number 1, the proper composition. So what should be the composition of the allergen immunotherapy? That is very important. And how we are administering it. The mode of administration. Also, it also depends on the proper antigen selection. If we are selecting wrong antigen, so that will be a problem for us. It will not work. But most important, if we have to choose the right patient for having the proper allergen immunotherapy effect, if we are selecting the patient wrong, the very purpose of allergen immunotherapy will be lost. So proper patient selection is very critical. And we should go through that. That is why our module 2 was on that clinical methods and history taking, the importance. And third module, Dr. Vedantan sir had told us a detailed how skin prick test can be utilized and not utilized, both for proper patient selection. So when it will not work, when we have poor patient selection, the patient is suffering from non-allergic disease, long-term disease, wrong antigen selection. We are not selecting the proper antigen. The quality of antigen is poor. The patient is suffering from multiple comorbid conditions. Maybe a 65 years old patient who is suffering from asthma and COPD. So many times we see this COAD type of patients, and there we are using this small allergen immunotherapy. So it will not work. When we have young patient actually suffering from allergic disease in a very early or mild disease type. And of course, the patient should be compliant to therapy. If these all criteria fulfilled, then the allergen immunotherapy will be working at maximum efficaciousness or effectiveness. So again, if we just revisit those factors increasing the clinical efficacy of allergen immunotherapy, number one, shorter duration of disease, early age. Initiation of the allergen immunotherapy occurs early in the course of the disease. Very minor involvement of the lower airways. The patient is well compliant and adherent to therapy. And this education needs to be spread from the very beginning of starting allergen immunotherapy. Otherwise, they will tell, doctor, you not tell me about this 3 to 5 years duration. This is a long duration, I cannot take. So from the very first day, we should be very clear. There should not be any hidden thing. We should tell our patient, this is a process for 3 to 5 years. And if we can reach a very high cumulative allergen immunotherapy dose, the efficacy will be maximum. So the study had shown efficacy of allergen immunotherapy is associated with a dose response curve too. So few another important but technical points we need to remember. We need to select few major ones. It is not possible to select all those allergens, and it is not right to. The last class, Vedantan sir had beautifully taught us about why we also, during our skin prick test, we should do the minimum testing according to the history. And then we need to select very small numbers of allergen for planning about the allergen immunotherapy. There are not that much studies and regarding with the food allergen desensitization. So it is not that approved, the food allergen immunotherapy. Though there are certain studies with peanut, milk, or type of oral allergen immunotherapy, but that they are not that much convincing yet. So we are not using food allergen immunotherapy. But with house dust mite, with cockroach, with some specific pollens, Alteria like molds, so we can use them for the purpose of allergen immunotherapy. But we need to select only a few major ones, not all. And as the cockroach antigen and the molds like Alteria, they have very high protease content. So if we mix molds and dust mite, so what happened? The dust mite protein in that particular vaccine will be degraded by this protease present in the molds. Similarly, we should not mix molds with pollens. So that will decrease the efficacy of pollens. Now we talk about the evidence. What are the different evidences we have? We already had discussed that they are indicated in case of allergic rhinitis, asthma, allergic asthma, and venom hypersensitivity. So a very important study, very good RCT done by Kritikos et al. They had shown there is a straight way 70% RRR, relative risk reduction, in the raguid allergen immunotherapy arm compared to antihistamine arm and INCS arm, intranasal corticosteroid arm, in the patients of allergic rhinitis. There are another studies that had been shown with house dust mite specific allergen immunotherapy, 50% relative risk reduction in the children with a 6-year follow-up, preventing neosensitization. So again, that is a very significant finding we need to remember. And a systematic review meta-analysis, including 17 clinical trials, had shown 35% relative risk reduction in terms of medication score reduction in seasonal allergic rhinitis patients. Again, this had been taken from our guideline prepared by Gaur et al. They had given 3 important meta-analysis report here. In allergic rhinitis, we can see the diamond is in the favor of allergen immunotherapy in this forest plot, and they are showing almost 14% relative risk reduction. Also the slit, the sublingual immunotherapy. There is again, the diamond is in favor of allergen immunotherapy. For allergic asthma, the subcutaneous immunotherapy, the diamond is showing statistically significant favor in terms of allergen immunotherapy. And slit also, the sublingual allergen immunotherapy, the diamond is in the side of allergen immunotherapy compared to placebo, but that is not statistically significant. So when we talk about allergen immunotherapy, how to use, the most important part is again the history taking. Then the clinical examination, they are going to confirm the diagnosis. But again, it is important to acknowledge, as variability is the rule of allergic disease, many times we will see patient when there is no clinical signs, because at that point of time, maybe the patient's symptoms are not there, the patient's clinical features are not suggestive of allergy. But at the night time, at the early morning, the patient had atypical symptoms when we cannot have the possibility to examine the patient. So it is again very important to note history is the key to diagnose allergic patient. Then of course, there is a role of skin prick test, which is one type of immunological test to detect the sensitization. But again, we need to re-emphasize, they will detect the sensitization only. We know the difference between sensitization and allergy now. So clinical allergy, to stamp the case as a pure clinical allergy patient, so we need to take the second history, and that can confirm this could be some major allergen for the patient. So second history is very critical before deciding on allergen immunotherapy, which comprised of, number one, a shared decision making. We need to tell about that 3 to 5 years story. The consent of the patient. There should not be anything hidden. between us and the patient. We need to take a proper history again to select the major allergen. And while deciding the major allergen, the other factors, the composition of the allergen immunotherapy need to be considered. And sometimes it is also difficult to depend on skin prick test only. And many of our allergology colleagues, they take the help from component resolved diagnostic here. But in our country, on the CRD, the problem is the cost. So counseling is the next important step we need to do before prescribing allergen immunotherapy. And most importantly, the information related to delayed perceivable effectiveness that should be provided to the patient. Otherwise, we will face a serious compliance issue. So we need to tell the patient the adherence to this allergen immunotherapy is very critical. And along with that, it is not like that I am starting allergen immunotherapy, so you will stop all the intranasal corticosteroids or inhalation corticosteroids or antihistamines. These two will go in hand. By the next visit, clinical examination and history taking, we may decide on de-escalating the dose, but you should not stop the drug. So this information should be provided with the patient. When we should not use allergen immunotherapy, if there is certain absolute contraindications, like the patient is suffering from uncontrolled persistent asthma. So FEV1 is less than 70% in spite of treatment, then we should not use it. The patient is suffering from some malignancy. Generally, pregnancy is a very tricky thing. We should not initiate allergen immunotherapy in pregnancy. But if a patient is already on allergen immunotherapy, we can advise those patients to continue allergen immunotherapy if they become pregnant, especially if they attain the maintenance dose. There is no harm to continue the allergen immunotherapy even in pregnancy. Children less than 2 years, that is the absolute contraindication for allergen immunotherapy. And of course, the AIDS. There are some relative contraindications. Number one, if a patient is taking beta blockers. Generally, why it is like that, we know. In our first class, we discussed about the anaphylaxis management. And if some anaphylaxis happened, the patient is already on beta blocker, it is very difficult to manage those cases. We need to use glucagon on top of adrenaline. After adrenaline also, the patient will not have that much response. So we need to use glucagon. So that is why the beta blocker is something relative contraindication. But again, we know that allergen immunotherapy induced anaphylaxis is not that common. It is a rare condition, rare side effect. Patient is suffering from some cardiovascular disease. Again, that is a relative contraindication. The reason is almost the same because if those patients suffer from one anaphylaxis, so that can deteriorate the condition. The patient is suffering from HIV, but CD4 count is more than 200. That is not absolute contraindication, but that is relative contraindication. The children suffering from allergic disease, but age group between 2 to 5 years. So that is a relative contraindication, not an absolute contraindication. Depending on some other factors, we can decide whether the patient will take allergen immunotherapy or not. Some psychiatric or mental disorder patient is suffering from chronic infections, autoimmune disorder, immunodeficiencies, or use of some immune suppressives. These all are relative contraindication to allergen immunotherapy. So when we talk about allergen immunotherapy, there is one phase that is build-up phase. Generally, we use 1 to 2 injections per week. Mainly after 3 to 6 months, this will take for the build-up phase. Sometimes we take up to 9 months also in some cases. So higher degree of sensitivity if it is there. So we need longer period to reach the maintenance phase. So when the maintenance phase, the patient will take the dose maybe between 2 to 4 weeks intervals. So initially 2 weeks interval, then we increase the gap to 3 weeks, then 4 weeks. But again, important to note, the average duration is 3 to 5 years. Generally, the dose is 6 to 20 microgram of major allergen per 1:10 dilution. And that dilution, we start with maybe 1:10,000, then 1:1,000, then 1:100, and finally 1:10. Some reactions like local reactions that can happen, they are common. But if a patient is suffering from some local reaction, that actually not predicting the systemic reaction. But of course, after giving this subcutaneous immunotherapy, 30-minute monitoring is very important to check for the anaphylaxis, if it is happening or not. And that time, that waiting room should have an access to adrenaline. Some important points we need to remember during this, if the patient is suffering from allergic asthma, we need to check the inhaler use, how they are using, check the PFR value, dosing errors, if it is happening or not. Sometimes we need to be careful while taking injection from a new vial. For an example, I am taking 1:50,000 solution vaccine. After finishing 1:50,000, now this today I will take 1:5,000 of solution. The first dose from that bottle, from that vial, when I am introducing, we need to be a little bit more careful, because there could be a problem in the very first dose, maybe due to the problems with the standardizations. So we need to be careful. Already allergy season, the patient is having some seasonal variation. The pollen exposures are there, and I am using vaccines, allergen immunotherapy against that specific pollen. So we need to be careful that time. So exacerbation of symptoms, the patient is suffering from severe allergic rhinitis symptoms. So that is the time we need to be a little bit cautious, because this type of symptoms predict severe adverse drug reactions. In general, this is the dosing frequency we can see from allergen immunotherapy guideline update on 2017. We can start with 1:5,000, 2 injections in a week, starting from 0.1 to reach 0.9, then 1:500, then follow up. The maintenance will be with 1:50. This is actually what we are doing in our center, that is Allergy Asthma Treatment Center in Kolkata. We can see here, we start with 1:5,000. And gradually, we generally use it 7 days interval like that, and followed by 1:5,000. This is one of our patients who were in a research, clinical research. We are conducting on allergen immunotherapy. So you can see the IgE and IgG4. Generally, we do it in when we are doing some clinical trial mode. Otherwise, it is not that much routinely advised, the IgE, IgG4. So we monitor the IgE, IgG4 at the baseline, that is between first and second file. And then after that, maybe after one year, we will again check that IgE, IgG4, and we check the difference between IgE and IgG4. This is actually the recommendation, dosage recommendation for different major allergens. For house dust mite, it should be 20 microgram per month. We need to reach that maintenance phase. And for pollens, it is 50 microgram per month. For cat and dog, it is 40, and alternaria for 3.5 microgram per month. So when we talk about safety of allergen immunotherapy, it is generally safe. The sublingual allergen immunotherapy, that may cause some local reaction like itchy or mouth, swelling of the buccal mucosa, abdominal pain, and sometimes rarely hives. But yes, sublingual immunotherapy is a little bit safer. And that is why generally not need for epinephrine, and patient can take this in home also. But subcutaneous immunotherapy, that may produce some local and systemic reactions, though rarely. Anaphylaxis, very rarely deaths have been reported. Those cases of death that had been seen, the patients were already suffering from some unstable asthma. So that is why if the patient, on top of all the medications, the FEV1 is less than 70%, it is not that wise to use allergen immunotherapy in those cases. And of course, we need to do the PFR before giving the subcutaneous immunotherapy. There are certain data which suggest the systemic reactions, female, they have more versus male, but that is something 2.9 versus 1.6. And if the age is increasing, the chances of systemic reactions will be more. And if initially it is 3 plus skin prick test response, so that will produce more systemic reactions. 5% of the systemic reactions are associated with 3 plus skin prick test responses. 58.4% of the systemic reactions that happened in the maintenance phase, and 60% of those that happen in the pollen session. So these are few important areas we need to remember. So local reactions not predict systemic reactions at all. And we can use pre-medication. Antihistamine pre-medications can be used. But again, that can have some small problems, like if we use antihistamine, that may mask the early symptoms of anaphylaxis. So this we also need to remember. So this picture had been taken from the Gradman and Haken et al. Paper from Journal of Allergy Clinical Immunology Practice. So we can see now the recommendation is to use allergen immunotherapy when we are having allergic rhinitis, already manifested allergic rhinitis, and the allergen immunotherapy had been used here. But we know that how the story, the natural history of allergy happens. So starting from asymptomatic but sensitized children to that have some more symptoms load is increasing, then the patient will become moderate to severe allergic rhinitis. So ultimately, we know that there is a high possibility of conversion to asthma too. So the concept is like that, whether we should use allergen immunotherapy early, because that not only target the natural history of the disease itself, but also the modifications, the immunological changes that happened inside us, that also can be targeted if we use it in early. We'll discuss this in our panel discussion with esteemed panelists today about these issues, that early initiation of allergen immunotherapy, how it is important. So timing is crucial for allergen immunotherapy. So we need to test early, treat early. Test means it is not only the lab test and some highly costly test, allergy test like that. Not only that, we should here test also include the history taking, because again, for allergy practice, if someone may ask which is the most important test, then we can tell them the most important test for allergy practice is to take a proper and detailed history. So history is such an important area in the field of allergy practice. So test early means here not only the fancy test, allergy test, but also ask the patient properly to get a full history to detect allergy. Treat early. How we can treat early? When it is indicated, we should not delay about initiation of allergen immunotherapy, because this can modify the disease process. And we talked about the atopic march, allergic march. This is the only possible solution which can reverse the march, the atopic march. So when we talk about allergen immunotherapy, what, when, and how. So summarizing that, this is the modality which can target T cells, therefore modify the disease process. But most importantly, we should choose the patient properly. Right patient selection is extremely crucial. For that, the history is there, skin prick test is there, but again, we need to rely upon the second history taking. Then the allergen selection, in that, in some subset, CRD has some role, component result diagnostic may have some role, but we need to rely on the history first. And here also, our industry, the pharmaceutical industry, we need to believe upon the standardization process, how they are standardizing that allergen. And we know how the allergen immunotherapy have a building up phase and maintenance phase. The safety assessments are crucial, local and systemic safety assessment, anaphylaxis management, we should be aware of that. For that, we should observe the patient for 30 minutes. And yes, this is a neglected area, but we need to assure the quality control of allergen extracts. So thank you again, and this is my mail ID. If you have any doubt, you can also mail me in this mail ID. So I just want to stop here my screen sharing. Just yeah. So again, thank you. Also, I think we have with us our distinguished panelist, Now we have Dr. Neeraj Gupta, we have Dr. P.C. Kathuria, and Dr. P.A. Mahesh sir. So welcome you all in this panel discussion. And I think Pranam sir, Pranam Gupta sir, Pranam Kathuria sir. So
good evening. Good evening.
Good evening, sir. So I think we can start today's panel discussion. At the onset, again, I want to introduce you all with our esteemed panelist, Professor P.A. Mahesh, who is the Professor of Pulmonary Medicine at JSMC Medical College at Mysore. And we have with us Professor P.C. Kathuria. Sir is also a very renowned allergen immunotherapy specialist test physician at New Delhi. Welcome, sir. And also we have with us Professor Neeraj Gupta. Sir is currently the director of also in the Diploma of Pediatric Allergy Asthma Immunology course. And he is also the associate professor at Gripmar, that is Sir Gangaram Hospital at New Delhi. Welcome, sir. So the one of our slide actually had shown the early initiation of allergen immunotherapy. Whether what is the possibility of that concept of initiating allergen immunotherapy early, and also we had also discussed an area, the age cutoff. So before 5 years of age, how much it is possible to use? May I ask Gupta sir, Dr. Neeraj Gupta sir, this question? So sir, what is your approach to that age criteria? And also, could you please elaborate regarding that, whether we can use allergen immunotherapy early, what we are using now today, if we can. I think, sir, some echo is coming. Yeah, now. Sir,
thank you, Dr. Shabu. Thank you, Dr. Shabu, for the question. And first of all, I would like to say good evening to Dr. Mahesh and Dr. Kathuria, sir. And I think hello to Dr. Danish. So Dr. Danish is my batchmate from MBBS. So anyway, coming back to your question. So first of all, I would like to congratulate you regarding a very lucid, beautiful talk on allergen immunotherapy, which has actually made our job much easier because you have beautifully explained many basic mechanisms, and then you have taken, you can say, like, you have given the right messages. So as you rightly explained, that allergen immunotherapy, what it is doing is that it is, you can say, like, exposing the immune system to the same allergen, and ultimately you are shifting or drifting the immune system from the allergenic to the non-allergenic arm. So I would like to give you a little, you can say, like, maturation process of this allergic and non-allergic arm, which starts in the fetal life. So there are two processes. One is Th2, another is Th1. So the Th2 process is usually considered the allergic arm, and the non-Th2, which is like the Th1, is considered to be non-allergic arm. So when the fetus is there, so this Th2 pathway, this get matured first, and then it is the duty of the external environment or the external agents when the child is born. Then at that time, if they come early in life, especially in infancy, that could be some sort of allergenic food, that could be some sort of environmental exposure, microbiota, whatsoever you want to name. Then at that time, what they do is that they tries to mature the Th1 arm, and ultimately it balances out the things. But when this exposure get delayed, then at that time the Th2 arm remain dominant, and these patients or these children become, you can say, like, have a tendency to become more allergic. Now, answer to your question is once again lying here only. So in allergen immunotherapy, what we are doing is that we are exposing the same allergen. So you rightly mentioned that if we try to try to inoculate that particular allergen much earlier in life, then at that time there are higher chances that the body's immune response will become non-allergenic pathway rather than the allergenic pathway. So you have shown one paper which was published in JACI recently, just now, in which you have shown that even before the, you can say like the pre or the early phases of rhinitis or early symptoms. So I would not like to take it as a one particular age cutoff, as a 5 years or so. I think that it is the disease severity or the disease maturity or the immune system, which is, you can say, like triggering the response, its maturity, that actually makes the difference. So if you expose the allergen, if you give that particular dose much earlier, so more likely that the immune system will go non-allergenic pathway. So what the guidelines say, you rightly mentioned that for the subcutaneous immunotherapy, they are mentioning about till 5 years beyond, and for sublingual immunotherapy, even the literature also recommends 3 to 4 years and beyond. But definitely, these age limits are, you can say, like narrowing down, and in the future, when we will be having much more better understanding of this therapy and better extracts, then we should be having, you can say, like much lower cutoffs, and they should be there to start with the allergen.
Thank you, sir. So with that same, sir, could you please also tell us regarding the atopic march when we talk about? So if we target one disease or one symptoms, we can say, of that whole syndrome, so we can also prevent the onset of new symptoms. Like if we start with allergic rhinitis, we can prevent allergic asthma. So on that concept, what is your thought, sir?
Yes. So for this, I would like to first explain the atopic march in 1 or 2 lines. So what is atopic march? Atopic march is a theoretical concept in which, first of all, the skin manifestations in the form of atopic dermatitis comes, and which are usually in early infancy, usually they are due to food mediated or food allergy mediated, but not always. So it is considered like nearly 1/3 of the patients with atopic dermatitis have IgE-mediated food allergy. And those, when the food is getting exposed through the skin, then at that time, this you can say like this Th2 response, which get the systemic travel through the blood, and then via the systemic travel, these all Th2 cells or all the activated mast cells, they get to the distant sites, and the common distant sites are the respiratory system, among the respiratory system, nose and the chest. And then uh, they wait, they get more activated when the new sensation or the new allergen comes later on in life, and then the patient start having, you can say, like symptoms of nasal discharge or rhinitis type of problem or asthma. So a typical atopic march is like atopic dermatitis followed by asthma followed by rhinitis. This is a theoretical concept, but in a given patient, it is possible that the different phenotypes of atopic march can be there. It could be only dermatitis, it could be only asthma, it could be only rhinitis, or even rhinitis comes first and dermatitis, this asthma comes later. This can also happen. So these are the different phenotypes. So what I want to say is that these dermatitis, asthma, and rhinitis, these seems to be the different phenotype of a common immune process or a common allergic process which manifest at different time period. So if we are able to, you can say, like target this particular immune process via immunotherapy or allergen immunotherapy, and we are able to immune switch, as you rightly mentioned, that the switching happens, and ultimately instead of IgE, the IgG production starts. So if we are able to halt that immune process, so the phenotypic expression, whether it is different systems, but the phenotypic expression is likely to be halted. And same way, it also says that it also reduces the chances of neosensitization. The newer allergen sensitization chances are also reduced.
Thank you, sir. Thank you very much. So now may I invite Professor Mahesh sir, Priya Mahesh sir. So regarding the patient selection, as we had also discussed how much important to select the right patient before starting the allergen immunotherapy. So can you, sir, guide us regarding this right patient selection process?
Yeah, thank you, Shambhu. First of all, let me congratulate you again on a very lucid presentation, and greetings to Dr. Kathuria as well as Niraj Gupta. I'm here yet. Now, it is very, very important that you select the ideal patient. Now, who is an ideal patient? Who has significant burden of clinical symptoms, who has significant burden of need for medications. See, somebody is getting one attack for 2 days in 1 year. So they must have significant clinical burden and significant medication burden. What is not given in the guideline, which I feel is extremely important, is when patients have progressive disease. Now, when you
I think, sir, there is some network connection from your side. We cannot hear you, sir, properly.
of disease. So in such cases, you actually don't wait for 5 years, then say I will give after 5 years when you have extremely, severe disease. So there are clinical situations when you may have to overrule the guidelines. So I do believe the progression, the rate of progression of clinical symptoms and rate of progression of requirement of medicines, for me, is an extremely critical point in history, which tells me how aggressively I have to treat this patient. Should I wait or should I start now? Guidelines. So that I believe it is still not there in any guidelines. No guidelines talk of progression of disease, but I feel it is critical. Now, how do we select the allergen? So I was very happy that you talked of the second history. See, most people just look at the skin prick test results and everything that is positive. We do find a lot of people in India still do that. Everything that is positive, they will give for 20 years. So this is not going to be useful at all because Indians are high IgE producers. The only study, as far as I know, done in the general population was the Europreval study that we did in 2008 to 2011 time. And where we screened 32,000 people in the general population, and around 850 we have done history of allergies, most of them. We have tested what is their skin prick test to foods, to 6 common aero allergens, as well as serum specific IgE. Now, Indians are very high IgE producers. The mean IgE was about 550, mean. Median, because it was not normally distributed, was around 240 plus, which is not more than that. So every single positive test would not be a candidate that it is clinically relevant. So because we are dealing with the type 1 reaction, if once you get a positive test, every single allergen, you have to follow this pathway. You have to first ask the patient whether they are exposed to the allergen. He's sitting in AC all the time, he's sensitized to Parthenium. Does it really? So you need to find out first whether the person is exposed to the allergen. Second, on exposure, does he have clinical symptoms within 2 hours after exposure? Then only we characterize and give clinical relevance to this. For something like pollens, when it is difficult, you can also look at the aerobiology calendar. For example, if you look at prosopis, Navaratri kind of pollen, with February to May being a larger peak or a higher peak than the one you get during the Navaratri. So does the patient's symptom is reaching the peak during April, May? If it is so, and outside the house, then prosopis gains prominence. If I know April, May, I am perfectly asymptomatic, then the prosopis sensitization has no clinical relevance. So within 2 hours on exposure, during the peak season of exposure, especially for some of these pollens, when you have, if you look at the calendar, you get the peak season. They should have maximum symptoms. So you will find one allergen is causing the allergic rhinitis, asthma. So then you need to further tease out and find out which allergen is causing which symptom and whether the maximum symptoms in that patient can be explained by exposure to that allergen. So this is a pathway that needs to be followed before you determine whether this is relevant or not. That is how you choose the patient and choose the allergen.
Okay, thank you, sir. So now may I ask and invite Professor Kathuria, sir. So welcome, sir. So the thing is that Mahesh sir has already discussed how to select the patient and how to select the allergen. But again, if you can also, sir, guide us regarding the composition of allergen. What should be the ideal steps before choosing the allergen composition right in a right way? And at the same time, also, may I ask you to give your opinion regarding the quality or how in our country the quality control of those allergen extracts had been maintained? What is the standardization process? So, please, sir, over to you.
Okay, thank you. My greetings to all. Really, I compliment Dr. Shambhu for taking this endeavor, and really, it is a good things for all the allergists in India to update ourselves what is happening in the rest part of the world also. The question is there that allergic disease is a systemic disease. One should not, it is not an organ specific. One should not take care of that is a allergic rhinitis. One should go now, we use the term high T2 inflammation. There are many 6 diseases are there: allergic rhinitis, rhinoconjunctivitis, allergic asthma, immunotherapy, rhinosinusitis. So these 6 diseases comes under the domain of the T2 inflammation. So treatment is specific, as you already explained very well. So we should look what is the timing. There is a window of opportunity. And this window of opportunity, as you told, 5 years more, but it is even 3. You see, if my child is there, he is already on ICS 400 microgram, but still he has got a recurrent hospitalization exacerbation. We have to look for the eosinophils. We have to look for the sensitization. And we should start. I know the story now present. The once the dubli came, this biologically it was 6 years old. Now the recent paper has come in 6 months you can give this biological. The same thing should be done with the allergen immunotherapy. There is a no age bar. And second point is that what you ask is about the how the composition should be there. You see, in our study we found that 80% of our patients they are polysensitive. These skin prick tests as well as the specific IgE extract based does not tell us the severity of the disease. They also does not indicate whether to start immunotherapy until unless, as Dr. Mahesh has given very correctly, to correlate with the history. So the update, as you told, the CRD has come in India. So only you have to select the patients and judicially select. I just give you one example. Most of our patients, they are using house dust mite, more than 50% of the patients. But it is only indicated when the DERPI 1 and DERPI 2 is positive, which can be detected only by the CRD. If DERPI other 10 is positive, tropomycin is there, then there is no use. Even if we use the allergens compositions containing the cross-reactive allergen in the extracts, it is a futile exercise. And the patients will fail. Even we introduce the new sensitization if we use the cross-reacting allergen. That is the new paper has come. So we have to very specific. That's why our allergens must be standardized. And if it is not standardized, at least we should not use those allergens which has no value for us. Cockroach is there, Alternaria is there. You see, 5 allergens are very significant. House dust mite, cockroach, Alternaria, dog and cat. These are the allergens, major allergens, as you mentioned in the talk. They should be standardized. Even cockroach is not standardized because it does not contain the immunodominant allergen. Alternaria is standardized. But what about the dog and cat is also standardized. Pollens are all standardized, but pollens in India can be taken. Composition can be taken, but the most important, as you mentioned in the talk, is the incompatibility. We have seen many prescriptions that patients, they use food even, mold even, cockroach even, in just 6 or 7 allergens. Now the studies are there. If you use only single allergens, even if the sensitized, you see, sensitization will be cross sensitization or useless sensitization, or there will be selective sensitization. Selective sensitizations, even I have published one paper, even after doing all this, nobody is looking for the late phase reaction. Our allergen immunotherapy is LPR, not for the EPR. EPR is there. If you look, the house dust mite is more than 8 millimeter. And if you look for it, will be LPR will be there. So we should ask the patient to wait for 1 hour after once we do the SPT. And if after 1 hour their selection is, even if it is positive, it is there, that is the allergens which is mostly immunological signal. So composition should be made like this. Low protease should not be mixed with the high protease. So another is there that the month, as Dr. Mahesh has very clearly mentioned, whether perennial case with this seasonal exacerbations, it should be noted down. Now, another is about the in India, what about the slit and skip is going on. This is very important and it is very painful for us that most of the specialists, whether they are ENT or other people, they are using the sublingual without knowing that it must be the tablet phase, not in the drop or a liquid formulation. Most, even if the FDI has approved, GINA guidelines has approved 2017, only in the tablet form. And that contains the 300 IR. Questionable. So I just submit that, but then you ask about the quality control. In our system, whatever the five are manufacturing company in India, but none of the manufacturing company, they give the microgram. None of them, they have got the standardization. They do the SD page. After SD page, they don't know whether this protein is IgE-mediated, means they don't do any affinity, avidity, but they just look for the protein. But that protein is allergenic, still they are not. So we are only at that stage, whether we are giving the cross-reactive allergen. This is really a sad story for us that we are not getting the standardized allergens. So in future, my submission is there, one should get standardized allergens anywhere from abroad, or if somebody can afford, one can procure tablet. Thank you. Any question?
Thank you, sir. Thank you for your insights on these very important issues, but at the same time, neglected issues regarding the standardization and how to actually improve the quality of our immunotherapy. Before going to the specific questions, we will take some questions that had been asked by the participants. May I take the question from Dr. Shuyog Phadke from Mumbai? He had asked, like, can allergen immunotherapy be given in a patient with autoimmune thyroiditis, anti-TPO antibody positive? So patient is on 75 microgram thyronorm, L-thyroxine replacement, and the hypothyroidism is under control, but history of allergic rhinitis and asthma, requires intranasal corticosteroid and inhalational corticosteroids twice a day. So moderate and persistent symptoms, sensitized to dust mites, perennial symptoms, patient is willing for immunotherapy. So what should be our approach for this particular patient? Yes, so Katuria sir, you want to?
See, in autoimmune disease, it is not contraindicated, but disease should not be active. There should not be high CRP, high ESR, or TSH level should be in the normal stage. We do in ankylosing spondylitis, we have done. Rheumatoid arthritis, we have done. So it is not contraindicated. The relative contraindication will be there if the disease is active. So disease activity must be checked.
Yeah. So actually, sir, just want to share one thought regarding this, because we had also published one paper on the question arised. One case of systematic lupus erythematosus came to our OPD, that is clinical pharmacology OPD, 2 years back, and he was on allergen immunotherapy. That 28-year-old man. So just the thing is that someone had commented like that, as you were taking allergen immunotherapy, you have this, maybe this is due to that allergen immunotherapy the SLE developed. So they came to us, the patient came to us, and that is the time when we need to approach to like all those cases of drug induced disorders. So we had gone through lots of literature searches, and we found that actually in SLE, the Th17 mediated immune reactions that got upregulated. But we know that there is no role of that Th1 upregulation. And in fact, in SLE, the Th2 become defective. The Treg cells become defective. So what happened? The allergen immunotherapy, again, the mechanical plausibility, the pharmacological plausibility was not matching to the development of this SLE, and we had given those recommendations because you know that could create some medical legal aspects also. So we had clearly mentioned that they do not have any link with this allergen immunotherapy and this development of SLE. So before making this type of big comments, we need to be little bit more aware, because that can generate some bad names on this type of novel therapies. So another questions asked by Dr. Bhaskar Krishnamurthy from KEM Mumbai. So he's asking, when a new vial is opened, do we need to change the dose, or monitoring for adverse event is sufficient? I think we had discussed new vial means when we are going stepping up the therapy. Maybe for an example, we start with 1:50,000 solution to 1:5,000 solution. Generally, again, we need to go back to point. If we start with 0.05 ml or 0.1 ml, so again, when we are starting 1:5,000 vial, so that could be the 0.05 ml or 0.1 ml, like that, because 0.5 ml of 1:50,000 vial is almost equivalent to 1:5,000 solutions, which is we are giving 0.1 ml. So that is why we are going down and again stepping up the concentration. But the problem arises when we use maintenance phase of therapy, like if we reach the 1:50 solution, and there we are using maybe 0.5 ml per 2 weeks. So one vial finished and we are using another vial, new vial. So that time we need to be a little bit careful for the first dose, because as it is first of all 1:50 solution, so very high concentration is there. So if we are using 0.5 ml or even more than that, that should be very much vigilantly looking after, because as Katuria sir also mentioned about some questions on standardizations, we don't know actually how much quantity is there, if something more allergic reactions happening to that. So for fast, or say maybe for first 2 doses, we need to be a little bit more careful. Otherwise, we can continue that. So any opinion from Gupta sir regarding this, how you were practicing there, the skit, and what is your general advice to the patients?
So I agree with you. I totally agree with you. Means like whatsoever has been discussed about the administration as well as the monitoring of immunotherapy. So I always say to even my colleagues also and to everyone that first of all, do not get afraid. So this is not something which is going to create any problem. And how many reactions you have really seen after a routine vaccination or routine immunization in children? So they are practically also very less. But still, you all are prepared. You have to be prepared for any possible reaction, because even a single reaction in probably 10 years or 20 years is sufficient enough to, you can say, like to give it a bad name. So similarly, immunotherapy also, whenever you are giving, you are prescribing, you have to be ready, you have to be prepared with the crash cart ready, you have to explain each and everything, you have to be ready with everything. Though we understand that these are practically safe, pretty safe, but still you don't know that when a particular, you can say like a bad luck reaction can happen, then at that particular time we need to be really ready with that. But vigilant monitoring, these all things are just necessary, and it's like no need to worry about the things if you have chosen the right patient, right allergen, right age, everything. If you have you can say done the right homework beforehand, so you should not land up in a problem.
Thank you, sir. Thank you. Yes, sir.
You see, it is a dose and time dependent. Once you increase changing the vial, it is okay. That one again you have to see the local reaction. We have found in practice, if for the first new vial, if the large local reaction is more than 10 centimeter, we should not increase the dose, because that will predict that this vial will produce the reaction. So even if no systemic reaction, but the large local, it is in the books also. And in such patients, the pre-medication is advised. First you give, next vial, 1 in 50 you have achieved, you give pre-medication. And it is found that if you give pre-medication with only 3 drugs, ketotifen, darifylline if the patient is asthmatic, or you can give antihistamine others, or the low dose of the steroids. No reaction. As you mentioned that it will mask the systemic reaction, now it is an old terminology. It will not mask the systemic reaction in low dose. If you give high dose, then it will mask the systemic reaction. So we can give pre-medication even in the practice parameter guidelines. It is there. Pre-medication if there is a large local reaction of more than 10%.
True, sir. True. On the regarding the masking, the symptoms are what we were mentioning, sir. When we are anticipating anaphylaxis, sometimes if we use antihistamines as a pre-medication, that can mask the early symptoms of anaphylaxis. And as we are waiting those patients for maybe 30 minutes or like that, so the patient may land up with anaphylaxis, but we cannot diagnose it. So generally, this also practice when we are talking about our COVID-19 vaccinations, you know, sir, there is a huge cry. Sometimes the allergic patients cannot take this some specific COVID-19 vaccine, and they need to be given these antihistamines. So this is why we were talking about those masking of symptoms, sir. So Mahesh sir, if you have any comment.
Yeah. See, what I do for this kit is whenever we open the next or a new vial of a maintenance dose, we reduce the dose that we give. Because the is used, we cannot guarantee that it has the same potency. It could be less, it could be same, it could be more, we don't know. So what is usually recommended is for a new vial, you reduce the dose a bit, and then you can escalate the dose in the next injection. So that's usually, I don't usually use any pre-medications. Once they've reached the maintenance, we reduce dose and observe, and then if they tolerate, we go ahead with the usual dose in the next injection.
Okay, sir. Okay. So again, one question asked by Dr. Amrita Swati from Patna. So madam is asking, like, any effect on allergen immunotherapy on fertility? Any studies to support that it is safe for male or female patients planning to conceive? As of now, I think there is no concern on that. Mahesh sir, can you have some?
Yeah, there is no such study to look at whether it has an impact on fertility. The only thing is we have observed that control of asthma is important for very sure what is the mechanism. We find if the asthma is not controlled, they find it difficult to conceive. I mean, the woman finds it difficult to conceive. Of course, it is stress. They will not be having regular periods, and so many of those things may be in play. But other than that, immunotherapy as such has no relation to the fertility. If it is continued during pregnancy, obviously it cannot have any. and other issues as well.
Okay, sir. So thank you, sir. So one question is again asked by Dr. Khirshagar from Bhopal. So Dr. Khirshagar is asking why in case of aged a 60 years male suffering from COAD, so can I start allergen immunotherapy here, as there is a component along with COPD, the patient is also having a allergic component too. So whether the allergen immunotherapy could also reduce some symptoms. So may I ask Dr. Katuria sir to comment on that?
You see, COPD or echo is a differentiated first. If it is a 70% is there, less than 70%, it is a relative contraindication. But you have to look for 30% of these patients, they have got a eosinophilic. If it is eosinophilic and the patient is sensitized, then you can add. But FE1 should be more than 70%. That is the otherwise uncontrolled asthma. It is allergen immunotherapy, subcutaneous is contraindicated, absolute contraindicated. But patients can put on sublingual if the patient is sensitized to major allergen. Sublingual can be advised because sublingual is not going to harm. So sublingual, then again the question is there, that is it a standardized allergen which we are using, or it is even in our practice also, even 70 years we give sublingual. In the patient of CVS we give sublingual. But it should be standardized. Standardized means dose should be proper. The daily dose of it should be given. If my dose has got a 500 therapeutic unit, it should be 500 therapeutic units. Otherwise, it is as a placebo.
Thank you, sir. Sir, Mahesh sir, please.
Yeah, see, if the patient has COPD, that is absolutely, there is no role for immunotherapy. Now, a chronic asthmatic will, suppose suffering for 20 years, will have airway remodeling. Here also, your spirometry will be similar to that of COPD. But this is due to chronic severe asthma for last, say, 20 years, 30 years. Now, in this patient, there is still a role. If you look at the mechanisms of immunotherapy, one of the mechanisms is the impact of this immunotherapy on the fibroblasts. So we have seen people with the airway remodeling, after 2 years, lung function, which was low, suddenly picks up. After 2 years, it takes a long time. But we have seen some cases where there is an impact of immunotherapy on the airway remodeling also. Now, some patients have a problem with the neutrophilic asthma. You will work on it. But if you look at immunotherapy, it also has an impact on TH17, which is critical for neutrophilic asthma. So you will find that patients who are not responding to inhaled steroids, here sputum induction shows predominant neutrophilia, but they still have, typical sensitization, but they also have mixed inflammation, eosinophilia along with neutrophilia. You may still find that these patients who may respond to immunotherapy because of the effect on TH17, TH9 also, both of them will bring in neutrophils into the airways. So the immunotherapy, though currently the guidelines will tell you that this is it, but we have observed in difficult patients that there are certain groups which are not in the guidelines which the patient will benefit from. But if it is COPD, there is smoking exposure for 30 years, COPD, then there is no indication for immunotherapy.
Thank you, sir. So now may I ask Dr. Neeraj Gupta, sir, because I think many of us who are viewing this will be interested to set up for an allergen immunotherapy clinic. So, sir, a few important points to build up an allergen immunotherapy clinic. Uh, Please, sir, can you tell us?
So I think it is the same thing like setting up an allergy clinic basically, rather than saying it's like an allergen immunotherapy clinic. So for any allergy clinic, it is you can say like needed that first of all it is the logistical support which is needed. So as for the logistical support, if the patient is entering in the reception area, then it has to be you can say like a well represented reception area in which he should be finding everything easy. The registration should be there, and then thereafter the you can say like a simple screening type of questionnaire should be there, that can be man-made or that can be now it time you can use artificial intelligence and using some iPads or probably some computer systems, something like that, so that can screen out certain things. And then in that particular area, even the educational material that should also be there, which is very important. And even a patient who is coming to you, or probably an attendant is coming to you, and you are providing some educational material which is providing you regarding the allergen avoidance and different type of allergic diseases or probable mechanisms of allergen immunotherapy or benefits of allergen immunotherapy. So all these things. So if they are there, if even if that particular patient or that particular attendant is not having a direct relevance at that particular time, but still it is very important to spread the awareness at that particular moment when the patient is really waiting for a doctor there. And then thereafter when he is going to greet or meet the doctor, then thereafter the doctor is assessing after the questionnaire and everything, assessing, prescribing the medications. Uh, Allergen immunotherapy, to my understanding, it should not be prescribed on the first visit, because on the first visit, it has to be, you can say, like the disease understanding, patient understanding, which is much more needed. And the patient is not here to receive the allergen immunotherapy, he is there to get the relief from the symptoms. So we need to chart out the plan, tell him about the systematic approach, take a detailed history, do some testing, and then come back to him and then ask him to get some medications depending upon whatsoever preventers, controllers we want, depending upon the disease. And then we need to ask about the avoidance measures and then review them. Review them after a set time period, let's say after 10 days or 14 days, and then just see that what is happening with the symptoms of the patient. And then now this is probably the time that if the patient has been compliant enough, still the symptoms are controlled, not controlled, then this is the time that we should introduce the concept of allergen immunotherapy and then see that how the patient is understanding it. Allergen immunotherapy should not be forced on someone. Allergen immunotherapy has to be mutually agreed. It has to be explained to the parent, explained to the patient, but they need to understand, they need to be ready for that. They need to be ready for that commitment of, you can say, like 4 to 5 years. Many times it happens that the patient starts allergen immunotherapy and after 2, 3, 4 months, they have to leave it because of a number of reasons. So that should not happen. So, and then once you are starting with allergen immunotherapy, definitely, as I earlier mentioned about vaccination. So same way, allergen immunotherapy also, it's a process in which it has to be done in a well coordinated manner. The doctor should be there, then a helper or probably a nurse should be there with you to administer and simultaneously to monitor the patient. That is also important. And then if there is any particular reaction which happens, then that need to be carefully monitored, managed there. And then what next steps needs to be done, that need to be done. If the patient is going home with certain injections, ideally the injection should be given in the physician's office, but sometimes because of the practical difficulties, the next vial, as Dr. Mahesh and Dr. Kathuria was mentioning, so the next vial or the new vial, first injection or second injection is usually done in the physician's office, and rest of the injections are sometimes asked by the patient or the attendant to get in their own, you can say, like area or the home. Then at that time, they need to be given some, you can say, like a plan, a action plan type of the thing, that suppose if this particular type of reaction happen, then you need to take this, you need to report to your local biophysician, or you need to report to this particular number and tell and that how to happen. So all these things needs to be in a systematic manner, that needs to be done, and then a periodic follow-up, which is very much mandatory. Normally in our clinical settings, we usually do go with the symptom score and the medication score. This usually suffices the need that whether the patient is responding to or not. But in research settings also, even certain molecular markers or the biomarkers which are there, which can actually help us in determining the response. But majority of the time, it is the clinical score and the medication score, symptom score and the medication score, which helps us.
Thank you, sir. Thank you very much. So now we need to wrap up the things. So may I ask Dr. Kathuria, sir, to have some final comments on this topic and what you want to address our delegates?
Friends, take home message. Allergen immunotherapy is the only therapy which can repair the impaired epithelial defect. That is the most important. None of the drug is available with us. It is the only therapy which can, that's why we call it is a modify the natural course of the disease. Means it repair the damage by the allergens. You see, virus is there. Virus will produce neuroinflammation. But the allergen will produce immune dysregulation. We can train the immunity, acquired immunity, innate immunity. We can regulate. But we cannot do the virus. Virus, you see, when corona was, everything was there. We are exposure to the rhinovirus or adenovirus is there. But these things will be there. At least we can train our immunity by giving allergen. And there are 3 P, please remember. Number 1, it can prevent the new sensitization, prevent the ongoing inflammation, and it can prevent the even progression of the disease, atopic march, as Dr. Gupta has told. And it has got a 3rd P, which is most important, which none of the drug has got. That is the persistent effect even after discontinuation. Even we have seen allergic rhinitis. We give for only 3 years and 20 years, nothing has happened. It is a persistent effect. None of the drug is there. And second point is there, that is the emergency action plan. If you compare with food allergy, drug allergy, insect allergy, these people, they live in a fear of a death. These patients, we can modify. Even the food, 60% of the children, as per the study in USA has come, unknowingly food anaphylaxis occurs once they take pizza or other things or any other chemicals unknowingly present. So these patients, now the food allergy is coming up. Milk, egg and peanut. But with the help of the biological. Biological has really revolutionized our treatment. We give biological even the first 8 weeks. And once the maintenance dose is achieved, no need of biological. And we have done a lot of the work on omalizumab. And if we use the biological, it is possible in future, in spite of giving 3 years. Why we are unable to convince our physicians, even pulmonologists, they don't refer. Because they think it is a 3 years treatment, long treatment, no efficacy. So they think it is a useless, but it is not useless because they don't understand the basic science, which are we are unable to convince them. The basic science is there. It is the re-epithelize the damaged impaired epithelium. If you remember this sentence, I think this message should go into the head of all the physicians, in the mind of the pulmonologist also. It will be, our work will be done. And this session will be also by Dr. Shambhu. Really, I compliment and congratulate.
Thank you, Kathuria, sir. So as Kathuria, sir, was mentioning about the training our immune system that is done by the allergen immunotherapy. So may I ask Professor Mahesh, sir, for his final comment? And regarding this training part, I just want to ask you, sir, how to train ourselves too, because that is, I think, allergy is one area which is very much neglected in our regular curriculum, and even in the postgraduate curriculum from your that is pulmonary medicine, pediatric medicine, general medicine, even in our other courses, like when we were doing our postdoctoral residency in clinical pharmacology, there is one paper on this drug allergy we need to do, and this skin prick test. But as a whole, this is something which is very much neglected. So what is your comment, sir, and how we can overcome that challenge?
See, the training actually there are only few training programs. There is hardly any medical college that is actually offering like in the Western world. I think that is the need of the hour. So if the training, if you see most of the people are pulmonologists, then pediatricians, then ENT. So these are the three groups actually handling the disease. There are hardly any medical colleges in the country that has an allergy department. So if it has to improve, the first thing, though the MCA has given permission for a diploma in allergy, so that MCA like DCH and DA, there is a provision for a diploma, but unfortunately, in most colleges, since the faculty belong to other departments, if you take my own medical college, we have four pulmonology MDs. So they are not willing for me to move into the allergy program because they will lose 2 seats. So why will they? So the first thing the MCI has to allow that any faculty hold the post, like what they did for DM. There was no DM. First DM started, MD people could be faculty for DM. Right? And now you need DM to have a DM course. But in the beginning, that was not there. So medical colleges, every medical college must have an allergy unit. Then only it will reach the mainstream. Otherwise, it's unlikely to reach the mainstream. It has to permit people to additionally hold for 5 years or 7 years until you have the training. So if a medical college has people from ENT, pediatrics, and pulmonology additionally holding or running the allergy unit and the diploma program, I think over a period of 5 to 7 years, you can even have MD in allergy. You can bring I am sure it will reach the mainstream in the next 15 years. Without that, there are good work. I know Neeraj is doing good work. CMC is doing in Bangalore. Dr. Nagendra Prasad is doing. Dr. Kathuria himself is running program. VP Chest is running a program for 47 years. But they are not 3-year strong courses like you have in MD. So passing people who have passed out are actually doing immunotherapy, probably around 10%. So that is one issue we had with the CMC training, though the training is very good. So 1-year training. But then after passing out, how many people are actually doing? So that is the impact of the training program, right? So unless you have it in the medical colleges, once it is there, then every department will know that there is an allergy department. Now people who go out, they say there is no department in medical college. What are these people doing? They don't have the awareness. And it's difficult to drum in that this is important until medical colleges, every medical college has an allergy unit. Then you will find that, everyone will be aware of the department. That's an only step.
True, sir, true. So as Dr. Neeraj Gupta, sir, is also with us, and he's also currently director of the very important course and very popular course of Diploma in Pediatric Allergy and Asthma. So, sir, what challenges you are facing, and how also we can, as Mahesh sir rightly mentioned, how we can incorporate it in our NMC regulated pathway. But again, sir, what is your experience with running this course, and how many of our delegates who are listening, they can be actually benefited by this type of course also?
So this type, the course which I am running is Diploma in Pediatric Allergy and Asthma. So this course we are running at Sir Gangaram Hospital. It's a 1-year course, and it is on the similar lines of CMC Vellore Diploma Allergy Asthma course, but it is more pediatric oriented. And we are having some physical sessions, we are having some virtual sessions, we are having some in between the course, you can say, like in between some exams, entrance exam also and exit exam also. So overall, it's a very robust course, and entry also is like you have a competition, and exit also is something like that. You have to really work and really read hard and really practice, and then only you can pass. But the problem is that after doing everything, the most common question which comes to us is that is it recognized? Can I means like write this on the paper and somebody is not going to penalize? So we still don't know the answer to that. Reason behind, as Dr. Mahesh was mentioning, that nothing is there from National Medical Council right now in India. Even if you ask that what is the definition of an allergist in India, nobody knows that, because there is no definition of allergist. We all call ourselves as allergist, but there is no definition of allergist. Who should be called? It should be board certified who has done 3-year course, or it should be somebody who has probably attended a training program for 3 days, and then he should call themselves as allergist. So who should be called up? So what I feel is that as it has already been mentioned by Dr. Mahesh, NMC, which was previous MCI, now NMC, they need to really come up, as it is the future. Allergy is the future disease. It is the current disease. It is the future disease. Our country is now moving towards, you can say, like more and more developed side. So we are moving from underdeveloped to the developed side. So we are definitely, you can say, like controlling more infections, and then more immune-mediated processes or more immune-mediated diseases. Allergy is one of them. They are coming up. They are increasing, and they are rapidly increasing. So this subject needs to come up at a medical college level, even in DNB program, National Board of Examination. So they need to, you can say, like come up with this type of course. We are in the talking terms with them. So the talks are still going on, and we are hopeful that another few years we should be having something definitely on the board. So the things have started. Even they have also realized that yes, these things needs to come up. So they have also you can say, like open up their options, and so we are in the talking terms with them. But my only concern is that it is not only the medical students teaching. What I feel is that we require certain other platforms also. Like for an example, when we are talking about medical colleges, so we are talking about those people who are doing or will be doing MBBS, or will be, you can say, like the future medical students. But what about the people who have already graduated, who have already got the post graduation? So whatsoever courses which are right now running, they still need to be existing to provide the practitioners who are already practicing the knowledge about that, so that they can upgrade their skills. And then simultaneously community education, that is also important. Even schools, colleges, like I have devised a program which is called as allergy awareness program, which I run with Delhi University in different schools, different colleges. So these colleges are non-medical colleges, so where we have created a module which is like a 30-hour module on allergies, which is more, you can say, like a interactive module in which we are discussing with them, teaching them about the healthy habits, how to prevent allergy, how to deal with anaphylaxis, how to recognize anaphylaxis, when to go to a doctor. So to the high school children and to the college going students. So more such awareness modules, more such awareness programs need to come up. Then the other thing is that community education at different other platforms, that could be media, that could be print media, that could be audiovisual media. So the all needs to come up. Even the factories or the places, restaurant owners, where all the food served, because there are maximum chances of adverse reactions to foods are there, and they are just not aware that what can happen and how to be managed. So all these things. So it's not only the question about just teaching the medical doctors. We need to really, really, really strengthen our system, so that we should, you can say, like penetrate each and every sector of the society to tell them that what it is, how bad it can be, and how seriously they should think about it, and how it can be prevented or treated. So these all things are really.
Thank you, sir. Thank you very much. So I think it is almost 2:07. So we have to conclude today's session. And at the onset, I am really thankful to have, we must say, like 3 doyens in the field of allergy medicine in India, starting from Professor P.C. Katuria sir, Professor P.A. Mahesh sir, and Professor Neeraj Gupta sir. So thank you for being present with us today, this panel discussion. And I again, at this onset, we just came to know that almost 154 delegates were there continuously with us for this particular module, and I'm thankful to all those doctors who were there. I'm just requesting you all to please submit your post-test questions answers in that Google form that had been submitted to you, and we will have the next session again on the next Sunday, and the time will be the same, and we are hoping to meet you all again in the next Sunday. So again, thank you all the respected panelists, sirs. So with that, I namaskar to all of you and goodbye. Thank you.
Thank you